All right, good morning. It's my great pleasure to be here today to open this session on diversity and equality in intensive care and medicine. I'm Pascal Gruber, I'm from London, and I think this topic is really important. It's been one of great debate and discussion over the last few years, and we have an excellent line of speakers this morning from all over the world, from the United Kingdom to Switzerland, to India. So it's my great pleasure to introduce each one, and I'm very excited about these talks. So I would like to introduce our first speaker, Victoria Metaxa. She's works at King's College Hospital in London, and she's one of the chairs of the Diversity Task Force for the European Society of Intensive Care Medicine.
Thank you very much. Well, good morning here in the UK, and it is a great privilege to be asked to participate here in this conference. And in this session on diversity and equality, I'm gonna talk to you about women. And I'm gonna mainly talk to you about the association between women and in this pandemic, women and the virus. And I'm going to look at the different roles that that women have as patients, as healthcare workers, as carers, and as leaders. So without further ado, I think we all know that at a global level, this virus is riskier and causes more damage to men than women. And this is a very, very nice report from the sex. Hello? Can you hear me? Oh, right, sorry. So from the Sex, Gender and COVID-19 report, which is a collaboration between Global Health 50/50. This is an international group for research on women, and the African Population and Research Center. So the slide shows what we know. It shows that for every 10 female cases, that there are 11 cases of COVID, that there are 12 hospitalizations, that there are more ICU admissions and more deaths and more confirmed COVID-19 deaths. So we do know that. What is very, very interesting is that even though we know that the virus, COVID-19, behaves differently in men than women, we don't have much sex disaggregated data. This is the Gender and COVID-19 database is the largest in the world that uses sex disaggregated data. Less than 50% of the countries provide data separately for men and for female. And this, as we'll see later on, is quite important. So this is another nice publication that talks about the biology of sex and COVID-19. And again, we see the difference between male and female. This is several pooled European countries and China. And you see that even in countries like Switzerland, which is the gray bar, where the cases are less in male than female, than everything else, hospitalization, ICU cases, deaths, are much more in male. Of course, all this has the caveat that the number of confirmed cases and hence the incidence depends largely on the testing strategy and the number of tests and what kind of test is being done. But despite that, we will see that this signal is very consistent. We know that, we've seen this. And if you look at this slide, you'll see that this is the case fatality rate, and as a ratio between male and female, and male is the orange color. And you can see that irrespective of the age group, definitely the case fatality is more to male than female. And that signal persists irrespective of the country, the specific demographics in the country, and independent of the testing strategies. So definitely there is a signal there. Why, you will ask me? And then I will tell you that we have long known that male and female differ in their susceptibility and response to viral infections. And we have known this since the human immunodeficiency virus, so HIV, where we have seen that females have up to 40% less circulating HIV RNA, but despite having less circulating RNA. And if you match male and female in respect to the HIV viral load, then females are 1.6% have a 1.6% higher risk of actually developing AIDS more than males. And we have seen this in influenza A viruses, where males are more exposed to the influenza, but yet there are reports that the fatality is greater in women. We have seen this with hepatitis B on the reverse, where men have more HBV DNA titers, have more incidence of HBV surface antigen, and exhibit more hepatocellular carcinoma. So male and female do not behave the same in response to viruses. A few reasons why. Well, we do know that the immune cells, both the number of the immune cells and the activity, so monocytes, dendritic cells, macrophages, the number of them and the activity is different, is more in female than it is in men. Also, the inflammatory response that on general women exhibit in viral infections is more pronounced than in male, and that is hormonal related as well. So differently in puberty, differently in menopause, differently in pregnancy. So there's a difference there. There's always also a difference in the adaptive immune system. So cell-mediated immune responses are different. So men have less number of CD3 and CD4 cells. The ratio between CD4 and CD8 is lower. And we also know that the response, the immune response to antigen stimulation, and that could be vaccination, is higher than females. So their response to infection is greater than in male. So definitely a difference. But is it only a biological difference? I'm not sure about that. So look at this slide where you see that males in blue definitely have more confirmed cases than females. But this is different, and it's significantly different depending on which country. So is this only biology? Or could it be something else? So could it be that, for example, in some countries, the use of public spaces is more, how to put it, allowed in men than in women? In some countries, women are not allowed to participate in the paid workforce, so they can't go out, use public transport, and go to work and coexist with other individuals. On the contrary, some countries have more pronounced female healthcare workforce, so then maybe the ratio becomes less than that. And don't forget that there is always a gender-related risk factors. So because of societal norms, men smoke more, drink more, they have more hypertension, they have more COPD, they're more susceptible than females. So definitely, yes, there's biology, but if we reduce everything to biological differences, then we ignore the great impact that societal structures, societal norms, and organizations have on exhibiting COVID-19. And we'll talk about this a little bit later on. So what about healthcare workers? So we've discussed this a little bit more, we touched upon it, and this is not a surprise. You'll see on the column bar chart on the right that nurses are significantly more in all over the world than men are. So this is the female to male ratio in nursing staff, and you can see predominantly female. What is also very interesting is on the left of the screen, you will see that there is the breakdown by age, and you will see that nurses continue to be throughout the ages more than men. But look at the yellow line, and that's physicians, so doctors. That is slightly different. So yes, there's more women than men, younger doctors, so maybe university, but that completely reverses by the older age groups. And something else, and this comes from the WHO Gender Equity Report, there's a pay gap that on average is 28%. So men get paid in healthcare 28% more than women. Maybe this is because women are less inclined to do full-time job. But even if you account for occupation and working hours, women will get paid about 11% less than their male counterparts, but I think that is a topic for a different discussion. So, greater nursing ratio, we know that nurses are frontline staff, so then clearly you can see, and you can see here, that female cases among healthcare workers, the cases in females are more. Of course, we've seen that something happens when the cases become patients, and then the ratio completely inverts, and the deaths, for example, are predominantly in men. We've seen this as patients. So what about women as carers? And when I talk about caring here, I will refer to the unpaid caring, both direct. So for example, breastfeeding a baby or looking after a partner that is ill, but also indirect, like cleaning the house or going for shopping. And I don't think that it will come as a surprise to anyone that this kind of unpaid labor is mainly done by women, but maybe the magnitude will surprise you. So 76% of all the unpaid caring happens all over the world, happens by women. And we're talking about significant hours, so 16 billion hours of unpaid care work every day around the globe. And 76% of that happens by women. And that means that women spend 3.2 times more hours per day doing these chores than men do. And that equates about 200 days per year for women versus about 60 days per man. And you understand that this is quite important. And why is this important? This is very important because then when a country brings about a policy, for example, as a support system or the furlough system that we have here in the UK, in Europe, then that is addressed only in paid labor. So all this unpaid labor somehow goes below the radar and is never compensated. We do care because we know that in times of uncertainty and disease, these times worsen gender inequalities for women. We've seen this in great reports that happened after the 2014-2016 Ebola virus pandemic in Africa, where we've seen that because women were caring for the infected individuals more, they run higher risks at contacting Ebola virus. And this is no different now for COVID-19. We also care because other measures like lockdown, quarantine, and school closures affect women more, because that means that children stay home more. And we do know that, again, the majority of women are the ones that will stay behind, stop working, and look after them. So yes, we do care, and this ties quite nicely, I think, to the next topic, which is women as leaders and women as policymakers. So this is from the WHO. It is their Gender Equity Again report of 104 countries, and it is wide knowledge that women make up the 70% of the global healthcare workforce. However, they do hold only 1/4 of leadership roles in healthcare. And even in the WHO itself, when they looked at the expert advisory panels, and these are the panels that make policy, right, around the world, only 34% of the members were women. And this percentage is markedly lower in the African regions. So, definitely less in leadership roles, and this is very, very important. So this is very important because in WHO, for example, it seems to be a conspicuous blindness or invisibility of women in healthcare organizational governance. So everybody knows women out there. Women are out there. Everybody knows women are the predominant unpaid carers. However, they're not included in policy making. So this policy making doesn't really represent them. Reason for that? Well, this is a report that was done after the Ebola crisis, but I think is very transferable to COVID-19. There seems to be a systemic bias. So that does not mean that all men are biased against women, but it does mean that there seems to be a systemic blindness of the economic structures that operate in favor of men as a gender against women. And that is very important because if we don't include women in the policy making, then all the decisions and the policies made around surveillance, around detection, and around prevention will not be representative of their views. And we've seen the problem with that, for example, with the furlough scheme. So doom and gloom, but fear not, there is a way forward. And this is a very, very nice publication by the international women in global research, in global healthcare. And they do provide this lovely algorithm that does say that gender inclusivity and diversity is really, really important. And they propose that there should be greater representation of women and minorities, but let's focus on women in the structures, in the decision-making bodies, because that way you'll have more sensitive approach and you will have more engagement in all levels of decision-making. And this way you can reap the benefits, and you can reap direct benefits. For example, you will have a workforce of women that are more empowered, that they're more educated and more trained. These women will also be healthier because they will be part of the development of strategies that will especially look at vulnerable population. And we've seen that in pandemics, women are by definition a vulnerable population. But there will be more additional benefits from this gender inclusivity. There will be more knowledge. There will be this mind pool that will be exploited more, greater innovation. And if you're into this, there's going to be this satisfaction that we've approached this pandemic more ethically and more equitably. So I'm going to conclude to say that I have read that this pandemic has been called the great equalizer, but I am not so sure about that, because epidemics and hence pandemics are gendered vulnerable. They created gender vulnerability. And we've seen that despite the fact that the mortality is higher in men in COVID-19, well, socioeconomically, the impact is different. So more women are frontline healthcare workers, more women spend more time doing unpaid caring, so they work less in paid work, they stay home more, there they can be victims of domestic violence more. But on the contrary, they're less as leaders at a global, country and organizational level. And this cannot continue to happen, because it's only with gender equal and with diversity in our decision making that we will be able to create a response that is adaptive and a recovery that is consistent and longer lasting in this horrible pandemic. Thank you very much.
This is a question: how do you think we can get greater representation in women? How do we go? What are the steps that we can do to encourage that?
So I know, so that's a very difficult question, but I think the first step to greater representation would be acknowledge that there's definitely a gap. So we do see this, and we've been talking about this in healthcare and in critical care. The gap is still there, both in participation in panels, in decision-making panels, in academia, in all, let's say, governance and decision-making structures. So we do know that there's a gap there. The first step would be acknowledging that. And I am not sure, Pascal, that across the board we have acknowledged this. But if that is acknowledged, then this unconscious bias can start being addressed. So, for example, if you have more women in a decision-making body, then the policy coming out of this body is going to be more representative. It's going to address more these nuances like childcare or staying home to look after someone that is sick better than not.
Maitra from Tata Memorial Hospital in all the way in India, who's going to be speaking to us about diversity in the intensive care unit. Thank you, Sheila.
Hello. It is indeed a great pleasure and an honor to be speaking on the World Day of the Critical Lung. And I am very grateful to the organizing committee, especially Professor Pablo Cardinal Fernandez for inviting me. So, greetings from Tata Memorial Hospital in Mumbai. I'm going to be speaking about diversity in the intensive care unit. I have no conflicts. I am a member of the ESICM diversity task force on diversity and equality. However, this talk will not reflect the views of ESICM, though I will be presenting one of the papers of the diversity workforce. So in the next 15 minutes, I'm going to be talking to you about diversity in intensive care unit. And what I'm going to cover is, what is diversity? Does it really matter? And what is the status of diversity today in intensive care medicine? And what should be a proposed way forward? So first, by definition, diversity means a condition of having many different elements. So when we talk about this in healthcare, and specifically in the intensive care unit, we mean differences in gender, racial, ethnic, socioeconomic, geographic, and also academic and professional background. So there should be diversity in all. And this includes people with different opinions, with different backgrounds. This includes degree and social experiences, also religious beliefs, political beliefs, sexual orientation, heritage, and even life experience. So this is what we mean by diversity. So in summary, we're talking about an ICU where you'd have people of with different gender, a good proportion of people from different gender, geographic regions, ethnicity, sexual orientation, socioeconomic background, multi-professionalism, cultural and religious balance. So does this really matter? Do we have evidence for this? So a lot of this, the studies which have been done on this comes from the corporate world or also from healthcare papers, but not very few. The data in intensive care unit is very sparse, but we have data to suggest that when there's diversity in the intensive care unit, there's clinicians can have a different perspective. They can have a better understanding of each other. Also, there's increased creativity and productivity in the intensive care unit, improved decision making, and this can also decrease discrimination. In terms of patient care, we have data to suggest that this facilitates better communication, also improves patient satisfaction. And there are studies to show that patients from backgrounds where they're traditionally underrepresented in medicine are more likely to serve in underserved areas, care for minorities, and poor and uninsured patients. And interestingly, in the academic session, you'll see that the work that is produced by diverse research teams are of higher quality and more impactful than those by less diverse teams. So definitely there is evidence to show that diversity has advantages in the intensive care unit. And I'll give you some examples of this. And this is a very interesting study that has shown the association among less specialty, race, ethnicity, practice locations. And this was a study done in California. And here they looked at 48,000 over 48,000 physicians. And this was a survey data that they looked at. And they found that minority physicians were more likely than their counterparts to work in unserved communities and also care for minority patients, poor patients, and uninsured patients. Of course, this was done among the primary healthcare workers. So we don't know what the situation may be in other university teaching hospitals, but definitely to improve healthcare settings for the underserved community, continued efforts should follow to increase physician diversity, and this is essential. This was another study that showed improved that patient-centered communication, ratings, and care of concordance of patients and physicians was much more improved when you had better diversity. So this was an interesting study where they had about 250 adults, and these were Afro-American patients and also white patients, and they received care from 31 physicians, and these were mixed, both Afro-American as well as white physicians. And here they found that the Afro-American patients who visited the physicians of the same race, they rated their medical visit to be more satisfying and participatory than when they visited physicians of other races. So increasing ethnic diversity among the physician may be the most immediate direct strategy to improve healthcare experiences for the members, especially from the ethnic minority. And there's also data from the ICU, and this is a paper that looks at the race and ethnicity satisfaction with communication in intensive care unit. And they have found that there is better satisfaction. And this was a paper that looked at end-of-life care experiences when there were physicians from different, more diverse backgrounds. And this looks at doctor-patient race concordance. Now, this is a study that showed that among each race ethnic group, that this was a survey that was conducted, and they found respondents, coordinate reported they reported greater satisfaction with physicians compared to respondents who were not race concordant. So these findings support that for continuation of efforts to increase the number of minority physicians, while placing greater emphasis, of course, on the ability of physicians to interact with patients not only of their own race but also of other races, but we must have more diversity in terms of race when we involve people in the intensive care unit. Now, coming to nurses, now cultural competency among nurses is very important to improve the quality of care and also communication. And this was a study that was done in Europe, 15 intensive care units, and they looked at European nurses and they were interviewed. And here they looked at European ICU cultural competency. And this was a cross-sectional survey. And what they found that nurses who were exposed to cultural diversity in different ways, either they were living in a multicultural country, or they spoke a second language, or they were visiting other countries. Now, this could actually influence their cultural competence. And they said, therefore, programs which facilitate multicultural clinical practice are strongly recommended in nursing education. What about among fellows? Now, this is a little older study, but it's looked at the diversity and emerging critical care fellow workforce, which is, of course, going to be the future workforce, the trainees, and the trend right from 2004 to 2014. And this was done in the United States of America. And they published greater to create logistic regression models, compared annual trends, and also representation of women and different ethnic groups. And what they found was that the demographics of the emerging critical care physician workforce reflected underrepresentation of women, and especially of racial and ethnic minorities. And that's why it's very important that future research is needed to elucidate the reasons why this underlying persistent underrepresentation of racial and ethnic minorities occur in the critical care community. Now, what about women in the intensive care unit? And this is a very nice study that's done by Dr. Bala Venkatesh, Sangeeta Mehta, and the group. And they've looked at the status, of course, though this is not representative of all the studies in all the regions of the world. It gives you a good snapshot of the scenario worldwide. And this was the proportion of females, trainees, fellows, examiners, board members. And this was from the College of Intensive Care Medicine, Australia and New Zealand. And they were looking right from 2016 to 2006 to 2017. So almost over a 10-year period. And if you can see that there wasn't a significant rise in the number of female trainees, though they were much more in proportion. If you look at the examiners and the members of the board members, there was a rise, but they were still at a much lower level. And if you look at the proportion of women in various councils or boards of intensive care societies, you will see that they are at a much, this is the percentage representation, was much lower, especially with some societies from Europe, World Federation, Oceania, etc., was much lower than SCCM and the Canadian societies. And they even looked at presidents from various international societies. Of course, all societies were not represented. And they found some societies did not have any female president. SCCM had 7 out of 17. And ANZICS and SICCM also had some representation, but poor representation in leadership positions of women was very evident from this study. Now, this was a critical care perspective that was published in the Blue Journal in 2017 by Sangeeta Mehta and the team. And they outlined 5 sort of proposals as to how to improve this representation of women in critical care. And they propose that critical care society should establish diversity policies for populating panels, their commission sharing and responsibility with both the chairs and the members. And it should be merit-based representation, and it should reflect sex, gender, geography, ethnicity, economy, and discipline. And also authors and documents and journal reports, the principles and the methods of the panel composition for the professional documents should be present. And you should also have available metrics on women's representation in various panels and definition documents, consensus documents, guidelines, etc. And gender parity policies should be incorporated. So there should be bylaws in various societies containing explicit targets and also to reflect the minimum proportion of women in that specialty. And most importantly, training in diversity is very important, and also to look for unconscious bias for all critical care academics, particularly for those in leadership positions. So these were 5 very nice proposals that were made for various societies. Now, this is a very interesting protocol that's just been published in the BMJ Open Access. And this is a protocol, it's a proposal for improving the gender equality in critical care medicine and how to establish priorities and strategies. And this is in 3 phases. This is just a protocol that has been published. And what they plan to do is first, of course, do a scoping review. And the second phase will be to do a modified Delphi consensus and to identify the various strategies to improve gender inequality and in the specialty of critical care medicine. And then the third phase, what they plan to do is conduct a one-day meeting for all the stakeholders to build capacity for the development and implementation of these top-ranked strategies. So see, these are some of the proposals for moving forward to increase the representation of women. And this is about multicultural care in the ICU, and this is among the nurses. And this is an international project, and this is called MICE, Multicultural Care in the European Intensive Care. This is a European initiative, and this looks at how to improve the cultural diversity among the nurses in European ICU. And this is the European Task Force for Diversity and Equality. And I am a member of this committee. And ESICM announced in 2015-18 a diversity task force. And they also announced that they would publish a draft policy, a code of conduct related to gender, gender identity, age, sexual orientation, race, culture, socioeconomic status, and also multi-professionalism, which was done very soon after in this very nice diversity paper that was published in the Intensive Care Medicine Journal and in September 2018. And this cartoon shows you the representation from various regions in the across all the continents of the female to the male population. The dark blue is the female, and it's given in percentages, and also the age distribution. And as you can see, the much younger females are in a higher proportion, but as you go towards ages where it can be in positions of responsibility because of their family commitment and childbearing, etc., there is lesser representation. And over the years, it has also been seen that ESICM, there has been increase in the representation of women on various committees, though there is scope for much more improvement. And the European Society of Intensive Care Medicine, the Diversity Task Force has created 3 working groups, one to look after sex, gender, identity, and sexual orientation, another one for ethnicity, cultural, and socio-economic status, and a third one targeting multi-professionalism. So I think this is a very important step forward by the society, and it's one of the first societies that's come up publicly and talked about what is their plan for ensuring diversity within the society. Now, this is a very nice statement from the National Institute of Health, which says workforce diversity is a scientific opportunity. So identifying, what they state is identifying psychological and social factors that mitigate individuals and institutional barriers to the workforce diversity is extremely important. And it's very important that institutions, they develop a scalable strategy and effective dissemination to sustain diversity within nationwide scientific workforce. And this can increase productivity and also improve the quality of the research if you have diversity in this area. So I'll end by saying that diversity in the intensive care unit is extremely important. It gives us a different perspective, better understanding. There can be increased creativity, also productivity, and improved decision-making among the clinician. And of course, all this also translates into better patient care. It's extremely important that administrators, critical care societies, and even individuals should work together towards promoting and facilitating diversity in the intensive care unit. And especially for women, part-time training and policies to minimize bullying, discrimination, sexual harassment behaviors for women in the workplace should be a focus of these kind of groups. And I think future research should focus on identifying the gaps that are present in establishing diversity in the intensive care unit, and also the best strategies to improve diversity in the intensive care unit. Thank you very much for your attention.
I would like to introduce our next speaker, Joanna Berger from Bern, Switzerland. And she will be talking about equality and diversity in medicine and some of the challenges we have and how we can overcome it.
So the male unless otherwise indicated concept, or seeing men as human default, is unfortunately an old habit deeply rooted in the history of mankind. Cave paintings, for example, are often of game animals, and so researchers have assumed that they were done by men or the hunters who have hunted these animals. Curiously, newer analyses of handprints that appear alongside these paintings have suggested that, in fact, the majority of them were actually done by women. The extent to which the male unless otherwise indicated term permeates our thinking may seem even less surprising when you realize that it is embedded in our daily language. The word man, like doctor, lawyer, researcher, or surgeon, are commonly used in an ambiguous way that is impossible to decide whether it refers to males or type of occupation in general. Research shows that when the generic masculine is used, people are more likely to recall famous men rather than famous women, or to estimate a profession as male dominated. So it all starts not in medicine, but in society in general, where, putting it in a rather defiant way, diversity occurs as a deviation from the male default. Well, bias is prevalent in every aspect of our lives, so our brains are hardwired to categorize things we encounter in order to make sense of the complicated world around us. However, biases can cause us to form prejudices against others, which allows for inequalities to form between different demographics. And this has obvious consequences for the workplace environment. Some significant statistics include 42% of women experiencing gender discrimination at work, both men and women being twice as likely to hire a male candidate, 1/3 of men and women believing that males are better at risk management, and 4% of CEO roles only being held by women of color, for example. These statistics reflect the so-called leaky pipeline, a metaphor for the way that women slowly disappear as one looks into particular career ladders. The leaky pipeline is also very important in medicine. Although women make up more than 50% of physicians in training and 78% of the entire health workforce, they comprise only 1/3 of the physician workforce in medicine. Women are also less likely to be promoted to faculty positions, they obtain less funding for research, and they hold fewer positions of leadership in medical societies and departments. This is all being more or less addressed by the two previous speakers. Importantly, they also progress through pay grades more slowly than men and are paid less. Some specialties are even less populated by females, and sadly, the gender disparity in medicine exists in several forms, through career progression, academic advancement, leadership roles, and remuneration, which leads invariably to a positive bias towards men. This positive bias is also observed in hiring, reviewing national grants, selection of leaders for large research centers, publication in prestigious medical journals, and speaking in conferences. Gender inequality at work is due to a variety of factors. I won't be able to address them all here, but there are some interesting theories worth mentioning. A plausible theory to explain the gender pay gap, for example, is the so-called pollution theory, which might also be extrapolated to understand why certain professions are underrepresented by a particular sex. This theory suggests that jobs which are dominated by women offer lower wages because of the presence of women within this occupation. As women enter an occupation, this reduces the amount of prestige associated with the job, and then men subsequently leave. Gender bias is also a significant cause of persistent gender gap. Therefore, it is important to detect the elements of discrimination. For example, this could relate to unconscious bias, that women with families have less experience than men because they have taken time out of work and they are therefore less qualified to be on a decision body. This is also called the motherhood penalty. Other obstacles in careers and academics stemming from females' experiences of inequality are called the so-called imposter syndrome. Women tend to underappreciate their capacity and achievements, and as a consequence, they're less likely than men to promote themselves, to apply for a job, to ask for a promotion, unless they meet all the necessary criteria. And yet, women's traits, such as being more intuitive, more empathic, more attentive to detail, or even a better listener, may contribute to superior patient outcomes. This is very elegantly depicted on the paper cited at the bottom of this slide. So what does the evidence show? Are women really that difficult? Are men really better? Well, actually, it's not. That's not the case. Gender diversity in decision making and participation in the workforce results in stronger economies, more productive institutions, and a more stable governance. Gender parity also maximizes academic productivity, and peer-reviewed publications with gender diverse authorships receive more citations and therefore are more popular than publications produced by single gender authorship teams. Moreover, it has been shown that gender diverse groups collaborate more effectively and exhibit higher collective intelligence. So what is it that we can do? Redressing the current gender gap in medicine will improve working conditions for all physicians and will contribute to a more stable workforce. But unfortunately, there is no magic pill, and research is lacking regarding effective strategies to reduce discrimination. However, I do believe that there are three main aspects worth mentioning. First of all, we need to increase the overall awareness of the gender gap topic. Second, we need to identify factors that discourage women and ethnic minorities to progress on their careers. And third, we need to tackle these issues very objectively, almost goal-oriented, in a gender-neutral and non-discriminative fashion. I will discuss some examples in the following slides. So first of all, zero tolerance to discrimination. Well, gender bias is very difficult to eliminate, in part because of the historical late entry of women into higher education and research. So probably the most important step that we can take, and in some instances also the most difficult, is to have zero tolerance for discrimination. The high proportion of women who report having been mistreated at work is very alarming. Such forms of conduct have a negative effect on the self and on the team and hamper career progression. So all healthcare institutions must have some sort of zero tolerance approach to discrimination. This includes issuing guidelines, enforcing accountability with clear consequences for inappropriate behavior. Furthermore, gender neutrality must be practiced by avoiding words and language that can reinforce gender stereotypes. To minimize the impact of gender bias on leadership appointments, formal selection processes and transparent processes should be used. And this includes, for example, so selection panels being blinded to gender whenever possible. For example, removing names from CVs in the initial selection process. That would be an idea. Another solution to overcome gender bias is to set gender-based targets or quotas for the promotion of women appointed to leadership positions or panels, or speaking at conferences, or even research funding. The World Economic Forum 2016 reports that setting targets for recruitment and retention of female employees is a crucial strategy to improve female representation across all industries. There is proportional representation, which is supported by many governments and universities like Victoria and Sheila already mentioned. However, quotas are controversial, as some argue that they undermine equality and discredit the women appointed to the designated female positions. And finally, welfare state policies incentivizing men to increase their participation in unpaid work, parental leave, or more time with family are also a way to neutralize gender imbalance. Raising awareness is an important concept. Regularly auditing and publishing data on female representation in medicine will increase the visibility of the gender imbalance, as the barriers that impede gender parity and leadership are deeply embedded in cultural norms. Reaching gender equity will require strengthening civil education, reinforcing the values of diversity and pluralism, and engaging all genders and generations. Commitment by men, particularly, to increase participation of women in leadership is fundamental. We know that there is limited existing data suggesting that discrimination is significantly worse in non-mainstream groups. And this is particularly even more significant when individual characteristics are intersectional. For example, if you are disabled and a person of color. As individuals, these minorities have limited power to confront diversity issues. So those in a position of power capable of decision-making, who are unfortunately in their majority white men, need to be actively trained and involved on issues about discrimination. Another important aspect is supporting equity measures. The structural change in the workplace is crucial for women's integration and advancement in the workforce. This includes transparent parental leave schemes accessible to men and women, workplace flexibility through flexible work hours and part-time appointments, on-site childcare, and even at the workplace or even at conferences. Mentoring programs should be carefully tailored to support women, as men are more likely than women to receive strategic career advice and to be recommended for career opportunities as a result of mentoring relationships. And dedicated efforts should encourage talented women to apply for leadership roles, including positions on boards, committees, or speaker engagements. On the other hand, developing effective professional networks and advocating for key structural change must actively engage men in the change process. This is an interesting summary of a worldwide survey on gender disparities in anesthesia, where all different strategies to overcome inequality are proposed and grouped by individual, departmental, institutional, and societal strategies. I particularly like it because it's broad enough to serve people with different contexts, as some measures may not be adequate in certain backgrounds. So to summarize, I would leave you with a plan of action to deal with the gender equality as was already addressed before, and that can obviously be adapted to each individual context. So first of all, we should all increase overall awareness of the gender gap topic. Second, we should clearly identify the factors that discourage women and ethnic minorities to progress on their career or academic tracks. And third, we should tackle these issues very objectively, very goal-oriented in a gender-neutral and non-discriminative fashion. So thank you.
Thank you very much, Joanna. That's really, really insightful and helpful. I have a question for you, Joanna. I guess, how do you think we should start measuring, or how can we measure units or departments that practice equality and diversity versus not? I mean, how do we go about measuring the benefits?
Well,
because you've given us loads of strategies that we should be putting in place at a practical level.
The main problem about the situation is that we can't really, so the measuring is difficult. There are some indexes proposed by the World Health Organization, which weigh different aspects of each department. So what do we have? What don't we have? And they have they've created some sort of index, and they can sort of like stratify departments and countries regarding this index. But overall, it is probably significant to start low and to go slow, and to start with changes that we can, so goals that we can see. So it is very difficult to say to each person, well, do this, because this may not work for them, because they may live in a country where women are treated differently. For example, in an Arab country where women have a different category as men, and they work in a different system, and they even may not work with male patients. So everyone should actually have to sit down and check what can we do in our context and to improve this a bit further.
Great, thank you very much. I guess I have a question for Sheila following your talk. Do you think promotion of equality and diversity should be coming from professional bodies like, you mentioned the ESICM or, critical care medicine, or is it something that should be coming from the ground up?
Thank you. That's a very important question, Pascal. I think it should be both. I think we should have a multi-pronged approach. We shouldn't just depend on societies, but societies play a very important role, because you have intensivists going to these meetings. You have all levels of intensivists coming there, which are from different parts of the globe. So it's a very good opportunity for societies, especially at meetings, to address this issue. Nevertheless, I don't think you can just rely on societies. And this has to be something that every institution, intensive care unit, administrators, even individuals should work together. It has to be first something that we have to acknowledge. that there is a problem, and we have to try to identify what the gap is, and also look at our own biases and try to see how best. And as the previous speaker has just highlighted, it cannot be a one size fits all approach. It has to be individualized based on which region in the world you are, what is the culture of that region. So based on that, you have to identify strategies. First, of course, know what is the proportion of the problem in the region, and then try to identify strategies based on the needs and situation of that intensive care unit. So I think it's a bit of everything, but the awareness is extremely important, and I think education in this area is very important, and having these kind of sessions in meetings is also very important to increase awareness. Thank you.
Thank you very much. I think we've run out of time, but I'd really like to thank all the speakers who've been contributed today. Thank you very much for a really great set of talks. And also just a note from everyone that there is the IWIN Congress in June next year in Catania in Italy. But thank you very much for everyone who's been speaking today.
Thank you.